webinars talking about the use of patient online, in particular long-term conditions. Mental health is the topic for today, and those are the people sitting in front of you on your screen at the moment. I'm Ralph Sullivan, recently retired GP from the Yorkshire Dales. First started doing patient online back in 2006, one of the first EMIS practices to get involved. And Dr. Imran Khan is a clinical support fellow at the college working with me on this, and he has a special interest in mental health and has done for many years. So what are we going to talk about? Well, this is the point of view that we look at for online access to records, and we're really talking about access to the records here. Certainly prescriptions, appointments are convenient, efficient, accurate, safe for people to use. But I'll leave you a second just to read this quote from a patient in Manchester who had started to use record access. And that, for me, sums up the whole point of record access. This is part of the core of providing person-centered care. And not only is that a good standard to go by, but actually it becomes very efficient because you are not having to explain, re-explain, explore patients' ideas and expectations. They come to consultations better informed, with a clear idea of what their priorities are, and actually makes the job a lot easier. So, in mental health, what do we think is important to learn about? Well, there are particular aspects to using record access patient online for people with mental health conditions where they may not be able to use it as safely and effectively as others. There are, as with any form of person-centered care, there's health literacy issues that you may want to resolve. And this is a computerized system. Digital inclusion is important. And as we all know, there are people, particularly people with serious long-term conditions, who are amongst the digitally excluded in society, and we'll address that. And then we're going to look at how you can use record access specifically to help people with mental health conditions, both to look at what is in their record, what results are coming back from investigations, and how actually using patient online improves and deepens your ability to provide care and support planning. So this program, I'm going to start with an introduction to patient online, what we're talking about, and the new RCGP Toolkit, which has been redeveloped and extended this year to include several clinical scenarios. We're going to talk about how patient online supports people with mental health conditions, and also importantly, in the context of physical long-term conditions, which are prevalent and carry a bigger impact on life expectancy in people with mental health conditions than the general population. And of course, I think everybody is aware that there are special precautions that you feel you need to take for patients with serious mental illness, and we'll discuss those, finishing with a clinical scenario that highlights some of the key issues that we've discussed. And at the time, there will be an option for questions. So you'll see on your screen where you can type in questions for us. So please, as you go along, let us know what questions you have, and we'll try and answer them at the end. So moving on, we're looking at this from the point of view of GPs in England, although the principles and how you might use patient online apply across the UK. In England, GPs have got a contractual requirement to provide facilities for booking and cancelling appointments, repeat medication, and access to what is called the detailed care records, summarised in the little graphic at the bottom of the screen there. Basically read codes, drugs, and some other bits and pieces around demographics. Of course, you can go beyond that and give full record access, which includes consultations and clinical correspondence. That can be very helpful, and sometimes it's the most useful thing for patients to have access to, and we'll discuss this in more detail later. Now, what do actually practices think about record access, online access to the detailed coded record? Well, we did a survey a couple of years ago. The respondents fell into the categories that you can see on the screen. 75% of them at that time were offering detailed coded records to their patients. And important result was the reasons why they would not just offer it, but recommend record access. The top two indications as the practices saw it was that patients who had access to their test records and the detailed coded record benefited from that, particularly in long-term condition care. Further down, there's proxy access there, and that is access to the patient's record for someone else, someone acting on their behalf, a carer, a close family member, somebody who can be trusted to use the access in the best interests of the patient. And although it comes at the bottom of the list, preparing for consultations perhaps doesn't seem as popular, but we would argue that actually that's a really important use of record access. And we'll talk about that shortly. So, what's happening out there? These are the latest figures from NHS Digital. 25% of the population have registered for either repeat prescriptions or for appointments. The numbers of people who have registered for access to the detailed coded record is lower, but it is gradually rising. And all practices in England are able to offer that and more. And just to put this into context, this is the results from my own practice. As you can see, we've got quite a high percentage of patients who have access to the detailed coded record. We've been doing it for a long time. The numbers have very, very gradually increased. There was never a big rush. The numbers were quite manageable, but we've got to 16% without feeling too much pressure from the workload of handling the new applications. You'll see we've got quite a few patients, but not the average number registered for appointments. And in fact, very few patients use online for appointments, but that's because we have a telephone triage system which picks up all the appointments requested for GPs other than routine follow-up appointments. So the vast majority of our appointments go through telephone triage, and therefore actually online doesn't help. But so these numbers always have to be interpreted in the context of the individual practice. These numbers come from the NHS Digital website, something called the GP Data Hub, and you can look at your own practice's numbers, see how you compare with your local practices and with national percentages, and see how they're changing as time goes by. So, we mentioned health literacy. If people are going to have access to their records, they need to understand what's in there. And one of the concerns that people have, practices have, is that if they give somebody access to their records, they're going to spend a lot of time informing them about what it all means. And actually what you're doing in supporting health literacy is actually improving the ability of the patient to look after themselves. And as it says there, over 50% of the adult population already use the internet for health information. So the computer is the sensible place for a lot of people to go. And so looking at something in their record online and then going to the internet to look further is a natural process. And it does improve their own ability to take responsibility and engage in their own care. There are things you can do in the practice, and there's a well-tested, well-tried and understood teach back, chunk and check system. And actually, you'll find a lot of information on the College Person-Centered Care Toolkit about that. Issues of digital exclusion. I think these sort of numbers here, the older patients have less familiarity with using the internet and that are perhaps less likely to be interested in record access. There are ways of helping patients to improve their digital abilities. The Good Things Foundation has done a lot of work in this area and shown that actually it is possible to enable people to have the level of digital literacy that you need to access patient online. Practices have concerns, clearly, about record access. Training the practice to know how to provide it, the workload of assessing patients' records and making decisions about whether somebody should be allowed to have record access, handling the patient's response to what they see. Some people have concerns about whether their record quality is good enough to make it public. There are safeguarding issues of vulnerable patients being coerced into allowing others to have access to the records. And in the current climate where practices are hugely stretched, you do need to have the motivation to feel, yes, this is right for us and right for the patients, and it's something we can put the energy and time into. Of course, I would argue that the benefits far outweigh the work, and the motivation is clear, and part of what we're talking about today is why that motivation should exist and does exist once you start to explore the possibilities. So, Royal College of GPs has been developing this patient online program for 3 years. The aim, as you can see, as I've written here, is to increase the awareness and confidence in using patient online. And it's intended for the whole practice team. Access to the toolkit is free. You don't have to be a college member. You don't even have to work in general practice. Access is very straightforward. The toolkit consists of guidance documents, and there are templates like templates for registration for new patients. There are other webinars, and we've published a set of podcasts as well. It's not just been one or two GPs in the college working on this. We've included work with Royal Colleges, with university staff and the voluntary sector, and individual experts, and of course patients have been involved throughout. This is what the Patient Online Toolkit covers. How to manage and how to deal with new applications, all the safeguarding issues, information governance, the sort of things that you need to know to be able to provide safe and effective record access, and of course how to gain the clinical benefit from putting the work in. And this is what the toolkit looks like. It's standard format for Royal College toolkits, and easy and clear to navigate through. The clinical exemplars are what we've been working on this year. Mental health is number 5 in this list, and they all bring out different aspects of how patient online can be merged into normal clinical care. Diabetes was the first one that we produced. They all contain webinars, podcasts, guidance documents, and links to key resources. And they cover all these elements of patient online one way or another. So there are principles about how to get on and do the work, how to get started providing record access for practices. Most practices have started already, but new staff joining the practice thinking about improving the way you do it, can find guidance there which can be used by individuals or by a team for training purposes. There are standard forms that a lot of practices do use now. I filled one of these myself at my own practice. And there's background information about how to improve data quality. What does a good record look like that's suitable for record access? And some of the safeguarding risks, this big one of patients who are vulnerable to being coerced into allowing someone else to look at their record against their will and for malicious purposes. Certainly something that it really does help the practice to understand, but something that you can work with and safely apply. And then there are links to other resources. This is not meant as an advert, but as far as I'm aware, it's the only system available at the moment, but it's a commercial system that will do a screen on coded records and text within GP records to look for any data that actually may be best hidden from the patient, particularly if the patient were to be coerced into allowing somebody else to have access. And of course, this example in front of you looks particularly at the possibility for coercion being part of a domestic abuse situation. But in mental health, there are things in mental health records that patients do find very sensitive and really do want to keep very private. So, just to summarise where we are so far, I've tried to talk about some of the benefits and barriers generally and how the Patient Online Toolkit from general practice from the Royal College of GPs is designed to support practices in providing patient online safely and effectively. Right, I will hand over to Imran now, who will talk more specifically about mental health.
Thanks, Ralph. So Ralph went through some of the benefits of using patient online in terms of booking and cancelling appointments, ordering repeat prescriptions, and I'm going to go through how that may be applied to mental health and patients with mental health issues generally and mental health conditions. So firstly, obviously, booking appointments can be potentially less intimidating. Patients who are particularly anxious, who have issues around telephoning the practice, or intimidated by the normal procedures for accessing the practice, may be less intimidated by being able to go online and booking a consultation without having to have any personal interaction, which may be more amenable to some people. Also, they may equally be more likely to cancel appointments, so there's a potential to reduce the DNA numbers. Also, we talked about ordering repeat prescriptions. This can be particularly difficult in patients who've got complex prescription regimes. Certainly patients who've got serious mental illness can have really complex prescription regimes, and it can help to manage some of those complex regimes. Patients can look online, they can see what they've ordered, when they've ordered. It allows them to access and order prescriptions in a more timely manner. It also provides them reminders of when they last ordered. They've got, the patient themselves have a better understanding of if they've ordered on time, a better idea of compliance. And it also alerts them to medication reviews, other review dates that are listed on Patient Online when they access their own record. But what we are really interested in is the detailed care record, detailed coded record, and this is where we think lots of benefits can be gained. It has lots of access to the patient's own health, basically, their problem list, their lifestyle and work codes, the examination results, test results, questionnaire scores that may have been carried out, care plan codes, like we said, past medications, allergies and adverse drug reactions, and any preventive healthcare. And Ralph did mention the little graphic there, and that's more or less what is in the detailed coded record. We did talk about, Ralph talked about the national survey that was done in 2018. This one was one that was done in 2013, looking at specifically what proportion were mental health related, and obviously it's increased since then, but 43% of the British population were using the internet for health related information, 35% of which was mental health related. Now we can only imagine that's increased since then, but there's a high proportion of people accessing the internet and looking specifically for mental health related information. And obviously the coded record offers a prompt for patients to look at their own care record, look at health, mental health, and mental health related diagnosis generally. And there was a large study done about 7 years ago by the Royal College of Psychiatrists who looked at the way people use the internet to improve their health literacy in the mental health area, and they found overall it improves outcomes. So actually having access to information improves outcomes, which is almost intuitive, but it's not something that everybody realizes. So obviously when patients go to the coded record, they have lots of information that is portrayed to them, their diagnosis, some of their medications. They may have questions about both of those, and there are lots of resources available on the internet. We've just put a couple up there. The Royal College of Psychiatrists has lots of information and health advice on particular diagnoses, so patients can go to have a look on there. They can see what the diagnosis means to them. Mental Health Organization has lots of information about various aspects of care, and obviously the big charities like Mind and Rethink who have more specific information around mental health areas and support, and third sector organizations that patients can access. And obviously lots of patients will have test results. Now, we've talked about test results and lots of our clinical exemplars, but it's no less relevant in mental health, where they could be on multiple different medications. Some will have specific testing like lithium or clozapine, although clozapine is not something that's done in general practice. Often it's coded still in the patient's record, so they may still want information, and both the Royal College of Psychiatrists and lab tests online have lots of information on clozapine, which the patient may not have been prompted to look at before. Ralph did mention the extended record access, and possibly this is, and Ralph talked a little bit about some of the difficulties associated with providing extended record access, but some of the benefits are that it gives patients access to their consultations, all the documents, hospital outpatient and discharge letters, although they may have already been sent them in the post. Often it's a good way of organising them. They could got quick access to them, and lots more practices are doing this, and they're seeing the benefits in terms of not being asked to replicate or not being asked for a specific report that would already have been given to them. And it's a way of forming a repository of their own health in a more complete way. And there are some disadvantages in terms of the overall clinical assurance required for it, but I think in the future this is the way general practice is going, and this is an area where the central government even are pushing the direction of patient access to their own health records. So in summary, the patients using the detailed coded record can identify any inaccuracies that might be present. So if they look through their record and say, actually, that's not correct, something's not up to date, something has been coded incorrectly, then they can address that, and in fact that improves patient care by having the correct information. Often we work in systems where the information is filtered through to other organisations such as out of hours, and even secondary care now have lots of access to primary care data. So if that information is more accurate, then it overall helps the patient. And I think the area that we are keen to promote is it generally improves patients' health literacy through access to the detailed coded record. It empowers them to become more involved in their own healthcare, to understanding, and like Ralph mentioned, to this idea that they're no longer a passenger, but they are in control of their health. And throughout, it's lots of people, like Ralph said, see test results as a key area, and with patients on difficult medications like lithium, blood tests are really important, and it's important for patients to have access to those results. I'm going to talk a little bit about mental health and comorbid disease. We know that patients with long-term conditions are 2 to 3 times more likely to experience mental health problems than the general public. Patients with cardiovascular, stroke, or any cardiovascular risk factor are actually 2 or 3 times more likely to have mental health problems. Patients with COPD or difficult asthma in older age can be up to 5 times more likely to have depression. So this can be a good way of getting them to engage in their own mental health. We know that patients with diabetes are 2 to 3 times more likely to have anxiety or depression. So Patient Online can help integrate mental health and physical health more closely. So although it may be an idea that patients would use Patient Online specifically for mental health, we know that those comorbid diseases are what reduces patients' life expectancy. So by engaging them in their record for mental health, for instance, there may be an opportunity to engage them in other aspects of their care if they have comorbid disease like COPD or diabetes. And we've got lots of guidance on the use of Patient Online in some of these more chronic long-term conditions such as diabetes, inflammatory arthritis, and dementia, and they're all on the RCGP toolkit that was mentioned earlier. So I'd encourage you to go there and have a look. And I guess what I'm trying to say is look at integrating some of the ideas that we've presented here with some of the chronic long-term conditions that we've discussed in other aspects of the toolkit. And I guess care planning then and priority setting becomes much more important when you have lots of different comorbid conditions, and it's become increasingly important in chronic conditions such as dementia and diabetes, that the importance of having an update care plan. And if patient has access to Patient Online, they're more likely to engage, understand what their priorities are, and have this idea of priority setting. So in summary, patient access to their coded record is relevant in mental illness, and the coded information enables person-centered care by allowing patients to more fully engage in access to their healthcare, and then priority setting, and then future engagement with their own health in general. Ralph's going to go through a bit about coercion now.
Yes. Hello. Thank you very much, Imran, who's tried to present the story of how giving people access to their records allows them to engage more fully and understand complex health issues, and to develop their own priorities and to make discussions with the GP, the practice nurse, more focused on what matters to them. And there's less need for us to be informing the patients. They come already well informed with good information. So there's really good reasons for doing it, but why isn't everybody doing it? And I think there are a number of things that worry practice. Well, I know there are a number of things that worry practice. What you have to be able to do record access safely. There's the technical stuff, like how do you ensure that you're giving access to the person that the record relates to? Can you be absolutely confident somebody isn't fooling you into giving them access to somebody else's record? There are concerns about vulnerable patients, and many patients, particularly with serious mental illness, are certainly vulnerable to being manipulated, to being abused by people who may want to take advantage of record access to control that person. One needs to be really careful about what the patient can actually see, because apart from obvious things like third-party confidential data that should be hidden so the patient can't see it because they have no right to see the confidential information about someone else that may be in their record, there are certain things that some patients particularly will find hurtful, harmful, upsetting, and you can, by clinically assuring, by checking that record before access is switched on, make sure that the patient can see that information that is safe to be seen straight away, And you can hide information, perhaps temporarily, till you've had a chance to discuss it and make sure that the patient understands what it's about and isn't going to be unnecessarily upset by seeing something that takes them by surprise. And one of the issues about records is that we as clinicians understand what the terms are, and you understand how the practice use terms and the language that you speak clinically within your practice, and the language you record in the notes. But some of that can be ambiguous to lay people, can be ambiguous to people from other areas of medicine and nursing. So there is certainly something about what constitutes good data quality, and there is advice on the college website about that. But of course, good data quality is not just important for record access, it's vital in terms of continuity of care, continuity within the practice, and increasingly continuity across the health and social care system. All these things work together. They're excellent for safe online record access, but actually it's the best thing for good clinical practice as well. So just to reinforce the concerns that people have that can be dealt with, people with mental illness are almost certainly increasingly vulnerable to coercion. They are potentially of increased sensitivity to what they see in the record. There may be things that they should not be upset about, but feel are either stigmatizing, or they don't want to accept, or they misinterpret. And the record itself is more likely to contain things that people find unsettling. So remember, there are circumstances where you actually may want to refuse, or in terms of deteriorating mental health, withdraw record access. That is a decision for the practice, and it's a decision for the practice alone. If the patient disagrees, you are the data control of the record. It is your responsibility to maintain the safety of the patient, and in their best interest, you may want to refuse or withdraw access. You can do that. And equally, you can accept or refuse a request to give another person access to the patient's record. This may be a family member who is the chief carer of somebody with serious mental health, and you may want to allow proxy access temporarily during an exacerbation of mental illness. The practice controls this, and it is your decision about what is done. It takes a little bit of care, but actually makes life easier once you have the system working, and it certainly helps patients. And there is plenty of guidance on how to do this safely. The principles discussed in guidance, like the paper on coercion, on safe online record access, apply for all patients, but particularly for patients with mental health conditions. And in the guidance on mental health on the toolkit, we go into this in more detail. So I'll pass you back to Imran, who's going to walk you through the scenario of Andrew Mason.
So I'm going to go through a relatively straightforward scenario. I think it's quite typical of modern day general practice. This is a simple scenario of Mr. Andrew Mason, who's a 32-year-old who over the last few months has had problems with his mood. The GP goes through his symptoms, and he finds he has multiple symptoms of depression. Mr. Mason reports that he drinks 22 units a week and smokes 20 cigarettes a day. The GP then carries out a PHQ-9 and GAD-7 and scores 19 and 11 respectively. This enables the GP to diagnose him with depression. He rightly refers him to local IAP services, and in agreement with the patient, agrees to start surgery 50 milligrams once a day, with a suggestion to review in 2 weeks' time, as is normal practice. So in this setting, I've highlighted some of the information that might be coded during this consultation. So he's had 22 units per week of alcohol, that's coded. 20 cigarettes a day, also something is coded. Now, often those two appear in QOF. They appear in local enhanced services, so they can all be used to feed into the practice system itself, and they are good practice. The GP carries out a PHQ-9 and GAD-7. Both can be coded, and their scores attached to those codes. The headline for the consultation may be depression, also coded. He's referred to local app services and then starts sertraline. So the 50 milligrams of sertraline will be in his coded record, both as a code and as a repeat, as an acute medication on his list of medications. In some practices, they put the review in as a diary entry, and some it's just coded as part of the consultation. So that actually, the review in 2 weeks may actually be coded as well in some practices. So this gives you an idea of all that information, and it actually hasn't required the GP do any more work. These are things that are a normal practice. They don't require any extra effort. This is information that will be available to the patient if he looks at his detailed coded record, and actually represents good practice. So in this scenario, Andrew can use his patient online access to his detailed coded record and use any transactional services that we talked earlier. That's booking appointments, cancelling appointments, looking at his medication. He sees his recent diagnosis of depression, his PHQ-9 and GAD-7 scores, his alcohol and cigarette use. So by looking at his patient online, he may have been briefly discussed that he had depression, but this gives him an opportunity to look, actually, my GP thinks I've got depression. I can use some of the resources that are available on the internet, including the Royal College of Psychiatrists or some of the other charities, the mental health charities websites, to look at what that means to him. PHQ-9 and GAD-7, they're both diagnostic or scoring tools that they use, and they're also recommended by NICE in their idea of good practice and using scoring as a way of stratifying things like depression and anxiety. So again, he may not have, when he was doing the scores and completing the questionnaires, understood what that meant. But again, this gives him an opportunity outside the consultation to look at what those scores mean, allow him to engage in what those scores mean and what the idea may be in the future, which may or may not have been explained to him during the consultation, because there may have been other time pressures in that consultation. His alcohol and cigarette use may be highlighted. Again, this is an opportunity for him to look at what this means to him. His medication list includes an acute prescription for sertraline daily, but he can't order a repeat. Again, may prompt him to understand that actually this is something that he'll need to contact the practice about. His review date may be noted as a diary entry and reminds him to make an appointment for review with his GP, which he may be able to do online. Like Ralph said, in certain circumstances where patients or practices don't operate all their appointments on a patient online basis, then that method might be slightly different depending on how urgent he may need that appointment. So several weeks later, his GP repeats his PHQ-9 and GAD-7, now 9 and 6 respectively, and he records those results. Again, that they will be coded in his coded record. Andrew agrees to continue the sertraline, and then his GP places it on repeat and suggests a review in a few months' time, and if at any other time if he needs a review. Andrew can continue to access all those transactional services and view his detailed record. It gives him an opportunity to engage with any of the other services that may be available on patient online. So in summary, this highlights how clinical coding can be used in a more straightforward case of depression to enable patient online to be used in a more meaningful way. Coding encourages best practice in this case, so the use of certain scoring tools, for example, is something that's promoted by NICE as a method of good practice, and it provides information accessible to the patient by a patient online at a time that's convenient to them, in a setting that's convenient to them, and it encourages them to use patient online to become more engaged. And the other thing that we talked about was this idea of being able to look at all the medications. It encourages safe prescribing. It gives patients an idea of medication reviews and review dates, and encourages patients to be more aware of actually the medications, the review of their medications. And again, it's all about engagement. Now that's quite a simple example we've done there. There's lots of information that will be coming out in a guidance document that goes through much more detailed scenarios, including patients with comorbid disease. And I think that the example that we've used is diabetes. And although we haven't talked about it much here, we've looked at using patient online in patients with serious mental illness, and how things like proxy access can enable them to gain all the benefits from patient online without having some of the risks associated to them directly accessing it themselves. So I'm just going to hand back over to Al.
Thank you very much. So yeah, in summary, we try to make a case for record access being supportive of normal care for mental health conditions, and to explain how access to the record empowers the patient to become more engaged and more aware of their health. And it certainly does, and there is evidence to show that it improves outcomes. And we think in mental health, although there are some concerns people have about the vulnerability of patients to misunderstanding or being upset by the record or failing to be able to keep it secure, that should not preclude practices from gaining the benefits of record access in terms of patient care and the efficiency and effectiveness with which care can be provided and patients can use the service. And of course, patient online is really helpful in the care of all long-term conditions, and as so many people with long-term and serious mental health do have comorbid physical disease, and vice versa, as Imran alluded to. It is not just about mental health. Record access supports serious and long-term condition care in all sorts of ways, and helps actually identify both the practice and the patient what the priorities are at any one time. And we do talk about this in the guidance. We talk about how somebody with diabetes may be able to concentrate on managing their diabetes well when their mental health condition is in remission or is less troublesome. But actually it helps both the patient and the practice realize that as mental health deteriorates, there has to be some loosening of concern about diabetes, and the mental health becomes a priority, and vice versa. And how do you manage that well? So what's next? Well, the full detailed guidance document will be published very shortly. We're recording a podcast today, which will be available through the RCGP podcast set, and we're continuing to work in collaboration with particularly the voluntary sector over providing further guidance. So thank you very much for attending the webinar. I hope you found it informative and thought-provoking. And I think we have a few questions that have... oh, actually, no, my mistake. I was misreading the indication here. But thank you. Either no questions means we weren't very interesting, or we explained ourselves very clearly. So anyway, thank you very much. We hope you found it worthwhile. Goodbye for now.